There are a wide variety of neuromuscular junction disorders, but really there are only two that may show up on your boards, and these are myasthenia gravis and Lambert-Eaton syndrome. Of the two, the most common is myasthenia gravis. If you recall the normal physiology of the neuromuscular junction, first an action potential passes down a presynaptic neuron. As it approaches the end, it opens a voltage-gated calcium channel, which allows neurotransmitter vesicles to be released from the presynaptic neuron. What is the neurotransmitter in the neuromuscular junction? Good, acetylcholine. As acetylcholine makes it to the motor end plate on the postsynaptic muscle cell, it binds to the acetylcholine receptors and triggers an action potential to propagate along the muscle fibers, leading to a muscle contraction. Do you remember what two types of receptors are stimulated by ACH? Good, nicotinic and muscarinic. So, what happens in myasthenia gravis? Well, patients have antibodies against the postsynaptic acetylcholine receptors. These antibodies destroy the postsynaptic receptors. This means that no matter how much stimulation comes from the nerve, it becomes very difficult to cause muscle contraction. These patients then end up presenting with difficulty contracting muscles that work very frequently, classically the eyelids and extraocular muscles, causing ptosis and diplopia. Generally, they may feel weak as well. What happens if the patients continue to use the muscle, as in climbing stairs? They have more and more difficulty using their muscles. If you think about it, this makes sense because the acetylcholine receptor is not responding to signals from the presynaptic neuron. No matter how hard you try, you can't get the levels of acetylcholine to increase enough to cause steady contractions. In terms of clinical vignettes, look for a patient, normally female, who complains of feeling weak and having trouble seeing, which gets progressively worse throughout the day. What should you be wary of in a patient that you feel confident has myasthenia gravis? Well, think about a thymoma. What diagnostic test can you order to look for a thymoma? Well, we use chest x-rays or CT scans. Now, how do we treat myasthenia gravis? Let's go back to the neuromuscular junction physiology. Normally, the acetylcholine that's released into the synaptic cleft is broken down by acetylcholinesterase quickly. However, if you inhibit this enzyme, you can effectively increase levels of acetylcholine in the cleft and inadvertently drive more muscles to contraction. This is also exactly how you confirm the diagnosis of myasthenia gravis, by giving an acetylcholinesterase inhibitor called edrophonium and seeing if symptoms improve. One important board's relevant fact is that both of these syndromes have a paraneoplastic relationship with particular tumors. Myasthenia gravis tends to occur in patients with underlying thymomas. In contrast, patients with small cell lung cancer are more likely to develop Lambert-Eaton syndrome. So now let's talk about Lambert-Eaton syndrome. Here, the problem starts earlier than the acetylcholine receptor. Antibodies are formed against the presynaptic neuronal voltage-gated calcium channels. Therefore, when patients send a signal to contract, the action potential travels along the neuron, gets to these voltage-gated calcium channels, and causes them to open. But since they're impaired by these antibodies, only a small amount of calcium enters the presynaptic neuron to allow for neurotransmitter release. What happens if not enough calcium is released? Well, there won't be enough neurotransmitter. This leads to a weak contraction. However, unlike myasthenia gravis, if more and more attempts are made, more signals are sent, so more calcium builds up in the presynaptic neuron. So what happens to the neurotransmitter release? Well, more is more, and stronger contractions will result. Contraction attempts, however, have to happen at a fairly rapid pace. Otherwise, the calcium will diffuse away and you won't get the benefit of calcium buildup. What do you expect would happen if you gave someone with Lambert-Eaton syndrome edrophonium? Well, not a whole lot. Their problem is not postsynaptic. Always look for a small cell lung cancer in these patients. Flash quiz. Which disease is a presynaptic problem? Lambert-Eaton syndrome or myasthenia gravis? Lambert-Eaton syndrome. Most commonly, myositis ossificans presents radiographically when calcium deposits are noticed within the muscles, often the upper or lower extremities, that have sustained physical trauma. Myositis ossificans is important because you can easily confuse it with osteosarcoma in the clinic. As you'll see from the name of this fact, the name scleroderma is not as commonly used anymore and actually has been in part replaced by the term systemic sclerosis. So what is scleroderma? You should think about this disease as a widespread, diffuse, uncontrolled deposition of collagen leading to fibrosis in the body that, like most autoimmune diseases, affects females. The skin appears tight and puffy. Many organ systems are affected, including the skin, renal, pulmonary, cardiovascular, and GI systems, which is the primary cause of mortality. Look for this triad: autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. There are two major types you should know for step 1. The first is called diffuse scleroderma, and this is exactly what it sounds like: a widespread disease affecting the skin and many visceral organs, and it's rapidly progressive. What antibody should you screen for? SCL70, or anti-DNA topoisomerase I antibody. Do you recall what topoisomerase I does? It relaxes supercoiled DNA by cutting one strand and then reannealing it. What does topoisomerase II do? It cuts both strands of the supercoiled DNA helix simultaneously. The second type is a form of limited scleroderma, which affects certain areas more specifically. This is called CREST syndrome and stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Usually these patients have fewer skin findings than people with diffuse sclerosis. And if they do, they tend to have it on their fingers and face. What antibody should you look for here? The anti-centromere antibody. Remember, this presentation won't necessarily sound like scleroderma immediately because there really won't be that many skin findings. Instead, there may be nonspecific skin findings on the fingers, some vague history of GERD, cold intolerance manifested by Raynaud's, and x-rays of the hands indicating calcium deposits under the skin. Flash quiz. What antibody indicates CREST syndrome? Anti-centromere antibody. Raynaud phenomenon is due to abnormal vasoconstriction of digital and skin arterioles from an excessive vascular response to cold or stress. Remember that it's normal to shunt blood flow from the skin in cold temperatures to limit the heat loss. It's also normal to see a similar situation under stress because you activate your sympathetic nervous system, which leads to vasoconstriction. When this condition is not associated with any other disease, it's called Raynaud's disease. Raynaud's disease is purely mediated by an excess of alpha receptors present on the vasculature in the patient's hands. An abundant amount of alpha receptors on vascular smooth muscles can lead to vasospasm and excessive vasoconstriction during times of cold and stress. Raynaud's disease, when in association with another disease such as systemic lupus erythematosus, CREST syndrome, or mixed connective tissue disease, is called Raynaud's syndrome. The pathophysiology is different. We see vascular problems due to vascular compromise because of the antibody-mediated vascular and endothelial cell damage associated with these diseases. Can you quickly tell me which antibody is associated with each of these diseases? In lupus, you should always think of anti-double-stranded DNA and anti-Smith antibodies. CREST syndrome, think of anti-centromere antibodies. In mixed connective tissue disease, think of anti-U1-RNP antibodies. The red arrow highlights the cyanosis from decreased blood flow. Now, how do we treat this? Well, the problem is excessive vasoconstriction and vasospasm. We give them a calcium channel blocker because without enough calcium, vascular smooth muscle cells cannot contract. Let's try a board-style question next. A 73-year-old woman complains of difficulty with swallowing liquids and skin color changes for about 1 year. She has abnormal stiffening of the skin covering her fingers and toes. Which antibody best indicates the disease process this patient has? The answer is A, anti-centromere antibody. This patient has CREST syndrome, which is classically associated with anti-centromere antibody. This patient is describing the esophageal dysmotility commonly seen in this disease, along with sclerodactyly and telangiectasias of the distal extremities. Be sure to make this association between the lab value anti-centromere antibody and the clinical symptoms seen in CREST syndrome. Alright, that's a wrap for pathology. Next up, dermatology.